Hello, Dr. Hall here, sharing some comments about skin disorders in pediatrics using the backdrop of Chapter 30 from Tagher and Knapp's 2024 textbook, Pediatric Nursing and Case Studies. So in looking at skin disorders, I first want to start with looking at the difference between adult and pediatric skin. Notice that here that the skin for an infant is thinner. We know we have greater body surface area. That makes the blood vessels closer to the skin. We also have a lot of hair on the body that goes away as we get bigger. Overactive sebaceous glands during puberty. And we have something called eccrine glands, sweat glands that release water, regulate body temperature. They're more prominent on the palms and soles of infants and present over the entire body. We have apocrine glands also located in the axilla and pubic areas, which become active at puberty. What interventions do we have for children and infants? Of course, we want to promote skin integrity, prevent infection, and promote comfort. And looking back at this slide, you'll see some ways to do. First disorder we're going to look at skin disorders. We're going to look at viral related skin disorders like measles and mumps, and then move on from them to some injuries that can occur to the skin. So impetigo, very prominent in children and infants, and only them. Adults don't usually get this disorder. It comes from a Staph aureus infection, which is a bacteria, and we find that there are little wheals or bullous marks on the trunk, face, buttocks, perineum, and limbs, and these are fluid-filled blisters. Or you could see non-bullous breakout, which is small vesicles that develop into plaques with kind of a honey crust on them, typically around the nose and the mouth. It's a self-limiting condition, and we just try to avoid secondary infections. It's a very itchy thing. So if it's a baby that has this, they're just going to be crying and, not really able to scratch at themselves, but children definitely do. Folliculitis is an infection of hair follicles that can happen for adults also. Again, usually the culprit is Staph aureus because of poor hygiene, wound drainage, exposure to contaminated water, and or shaving, being a little older there. What's it look like? Small pustules, and there are pictures of all of these in your textbook, so I do want to recommend that you go back and look at the pictures. And again, we want to prevent secondary infection. Cellulitis, localized inflammation and infection of subcutaneous tissue, is secondary to trauma. So if I have skin trauma and I get an infection in there, it becomes inflamed. I have cellulitis. Mild cases are treated on an outpatient basis. More extensive cases are treated inpatient. So for example, a venomous snake bite causes cellulitis, and because it's created from venom, kids are hospitalized and treated with IV antibiotics. Is the following statement true or false? Children can stop taking oral cephalexin as soon as the warmth and redness from their cellulitis disappears. So really we're asking, if you're prescribed an antibiotic, do you have to take all? You should continue the full course always with an antibiotic. Measles, highly contagious viral infection, usually children or infants. Vaccination has decreased the incidence here, but we see a lot of migration of folks into the United States that don't have access or have made a decision not to immunize their children. And you can see here what it looks like. Probably all of us that are connected to this conversation have had measles. mild fever, conjunctivitis, you have a cough, and there are spots and little red rashy breakout. What do we do for that? We can give ribavirin or IV gamma globulin if needed. Sometimes kids are admitted to the hospital with measles, but not always. And then here are some of the pictures from your book that describe what measles is like. Mumps, self-limiting, again, viral infection. Vaccinations have decreased this incidence also. Children are contagious for 7 days before and 9 days after the onset of parotid swelling. Your parotid glands are on either side of your neck, so in olden days you saw people wrap a towel around the chin and the neck and the head just to give some support there. Supportive pain medications are used. Rubella is German measles. We also vaccinate for that. It is another viral infection. Avoid contact with pregnant persons can cause congenital rubella syndrome in the fetus. And it's this irregular macular rash that you'll see. And again, we manage fever and prevent dehydration. A picture of rubella. They all kind of look about the same, don't they? Which of the following diseases can be prevented by immunization? Measles, mumps, or rubella. They're all viral infections. So yes, all of them can be prevented due to vaccination. Varicella is an extremely contagious herpes virus, also known as chickenpox. And if you commonly get cold sores about the face and mouth, you have a different kind of herpes, but you're more prone to getting varicella virus. Transmitted through contact with weeping lesions. Children are contagious 1 to 2 days before the rash appears. Contagious. Contact dermatitis is an irritant. Adults get this too. Repetitive contact with an irritant, physical, mechanical, or chemical. Some babies are actually allergic to Desitin and they break out rather than having Desitin help. So you have to be very careful with selecting any kind of topical for infants. It is T-cell mediated, and we talked about that. Diaper contact dermatitis, that's what I'm talking about here. Contact dermatitis also can look like a rash. We want to find a history that will usually uncover the cause of the rash, and once you eradicate or get rid of the contact, then the rash can be medicated and treated. Erythema multiforme, it's acute hypersensitivity reaction. It may mimic Stevens-Johnson syndrome. We're going to talk about Stevens-Johnson syndrome and epidermolysis bullosa in class. So this disorder, Stevens-Johnson's or erythema multiforme, you have to remember that our skin extends down through our alimentary canal, through the mouth, down through the esophagus, stomach, small bowel, large bowel, out through the rectum. All of that is considered skin and can be inflamed and then slough off. That's what Stevens-Johnson's is. Very severe, and we'll talk about this more in class. Urticaria, self-limiting allergic reaction again, also known as hives, and they come and they go. Caused by IgE reaction to allergic triggers, and it's a transient sort of small little wheal that will go away. And I don't mean wheel like on your car, a little wheel on your skin. Infestations, lice and scabies. You can read about that in your book here. Typically, we get concerned about this with children because they're school age and sharing, you know how kids are. They share toys and hats and coats and everything. Burns, thermal or chemical types. Children should never be burnt. We should protect them from sunlight and getting a bad sunburn. And burns for children and infants usually indicate some type of abuse. Clinical presentation depends on the type and severity of the burn. We do perform primary and secondary surveys on burns in your adult classes. We talk more about that. It's no different for children and infants other than, you know, examining a child or an infant, which is different. And then we monitor for cardiovascular collapse or respiratory problems if there's a severe burn. This picture is just showing you first, second, third, and fourth degree burn. So first degree burn is the first layer of your skin, the epithelial layer of your skin. A second degree burn can have some blisters. Third degree doesn't hurt because the nerve endings have been burnt off, and fourth degree is deep bone. So here's a slide about types of burn grafts. You can look at that on your own. What do we do for burns? Same things we do for adults, with very high precaution for respiratory arrest, because infants and children are more prone to respiratory events than cardiac events. We want to prevent dehydration, give adequate fluid volume, definitely promote pain relief. Burns are very, very painful. So we promote wound healing, covering the wound. So you might see Silvadene cream used to cover a wound. It keeps the air current from touching the nerve endings that are exposed. We prevent infection and provide psychosocial support not only for the children and the babies, but for their families. Thermal injuries here, I mentioned sunburn. Frostbite also can occur, long exposure to the cold. So adult supervision needs to always be in place when little guys are outside playing in the snow. Is the following statement true or false? Desquamation occurs in sunburn, but not in frostbite. So if you quickly looked at the previous, you would know only in sunburn, which is a self-limiting condition. Frostbite does not desquamate or have cells fall off or, you know, peel back, but it often requires surgical debridement. Then we have insect stings and spider bites, which you can read about. Human and animal bites here. Human bites result in an occlusion injury. We treat with wound debridement, irrigation, antibiotics. One thing I will emphasize here is that we have to leave bites open. So we're not going to suture them completely closed because of the infestation of bacterial saliva that comes from a bite.